Hi, my name is CJ Shoemaker, and this is my exercise 318 benchmark final video. Today I'll be going over my assessment and corrective exercise strategy for the chronic ankle sprain, and we'll be focusing just on the whole ankle as a region. So first for the assessment, I would start with a static posture assessment, looking for signs like foot flattening, external rotation, things like that. And then next, I would move them into a dynamic assessment if I see fit, if they would be able to perform it and they don't have any super big weaknesses or things like that. So I'd probably move them into a overhead squat to check for foot and ankle compensations. Also, manual muscle testing would help assess the dorsiflexion and the inversion strength. So kind of working that ankle through its full ranges of motion, seeing what things are tighter, if the person is getting any pain from any of the movements that we'd be working through. For chronic ankle sprains, the overactive muscles that are typically shown are the peroneals and the gastroc-soleus complex. And then for the underactive muscles, the anterior tibialis, posterior tibialis, and all of the intrinsic foot stabilizer muscles would be the muscles that are overactive and underactive. And common impairments decrease dorsiflexion and cause poor balance and give weak ankle control to the patient. So for some of the causes for these overactive and underactive muscles and impairments throughout, they're often caused by repeated ankle sprains. So just the ankle is tricky because if you sprain it once, it's such a complex region of the body that it's easy to sprain again, which overstretch the ligaments and cause instability, which again can cause you to sprain them multiple times. So because of that happening, this leads to overactive peroneals and calves weaken as well as the stabilizers like the tibialis anterior and posterior. So for the corrective exercise strategy, we'll be going through the inhibitory technique, the lengthening technique, and then the isolated strengthening technique and the dynamic movement. So for each of those, we'll first apply foam rolling to the peroneals for the inhibitory technique, foam rolling to the peroneals and the calves. This will help reduce muscle tightness and improve mobility. That way, after we start doing this, we can go on to stretching and working through different strengthening activities, but we want to make sure that the muscles are first inhibited to reduce muscle tightness and improve mobility before we go on and we do that. Each muscle group should be rolled for about 30 to 60 seconds, and if we're witnessing the patient go through these foam rolling techniques, if they have any pain or any tender spots that we can see or they communicate, we want to pause and kind of really work out those specific areas. And I'll have that demonstrated here. So for the peroneal SMR foam rolling here, you can see it's pretty easy. I don't have a foam roller, but we're working with what we got. But I honestly like using a baseball or a golf ball just because it's a smaller muscle that you're working here. And then, just working it from top to bottom all the way through, slow and controlled. Pretty much it. And next for the calves, same thing. Just rotating towards the posterior side on the calves, rolling it up and down, slow and controlled for about 30 seconds each here. So next for the lengthening technique, we're going to perform static stretching on the same overactive muscles, the peroneals and the gastroc-soleus complex. For the peroneals, you want to gently invert and dorsiflex the foot, holding that stretch for about 30 seconds. And for the calves, you're going to use a standing wall stretch, keeping the heel down and the back leg straight. again, holding that stretch for about 30 seconds. I'll demonstrate these here. So for the peroneal stretch, you're going to be sitting with the hurt ankle crossed over onto the other leg. You're going to be dorsiflexing that foot like you see here, and then inverting it with both hands, and you should feel a stretch all the way up that side of your leg through the peroneal, holding that for about 30 seconds. I'll just show a different view here: dorsiflex, inversion, and holding that stretch here for about 30 seconds. So for the gastroc soleus stretch, you're going to be standing at a wall, keeping both feet straight, putting that hurt foot back, and then bending the front foot to kind of feel the stretch through the entire back leg and in the calf. Holding that for about 30 seconds. You can go as deep as you like and what feels comfortable. So next, for the strengthening phase of the corrective exercise continuum, you'll be strengthening the same underactive muscles. So for the anterior tibialis, you're going to perform resisted dorsiflexion with like a resistance band, really trying to work through that dorsiflexion. Probably have the trainer holding the resistance band out and then having the patient work through. I'll have these demonstrated at the end of this section. And then for the anterior tibialis, you're going to perform resisted inversion with a resistance band. So kind of the same thing, but just working through that inversion to strengthen that posterior tib. And then also including some isometric holds to reinforce stability at the end range. So after we're done here, then you kind of just have them holding that resistance band still, and probably for about 30 to 60 seconds, and depending on how they feel. And then that'll really help reinforce that stability after the strengthening activity. So next we have the resistance band dorsiflexion. Just having the trainer hold the band, giving it a little resistance, and then dorsiflexing the foot through its full range of motion as much as you can without pain. Holding it for a bit at the top and really controlling the band back down is important to focus on here. So this next one's a little difficult to set up, but you can see I have on the hurt foot the band tied around with a knot on the outside, and then putting the other side of the band on the other foot and crossing them over. And then from there, you're just using the other foot to kind of strengthen or weaken the resistance, and then inverting the ankle. And I'll show it from a different angle here so you can kind of see it a little bit better, but really making sure you're just working through the movement. And if it feels easier, you can move that foot out a little bit, and then working through controlling the band back. So next, for the dynamic movement, we'll work on full body stability and proprioception. For this, you can use exercises like single leg balance. Depending on where they're at in their recovery, you can do this just on stable ground, or you can include a Bosu ball to kind of make it a little bit more challenging, and really give that stability work for the patient, but only do that if they seem ready for it, or if they're strengthened towards the end of their recovery. You can also do things like lateral bounding, again, if this is a little bit more challenging for them, so you're going to want to make sure that they're really prepared to do this. Training the ankle in like more of a dynamic condition. So I'll go ahead and demonstrate those here as well. So here I'll be showing a little bit of a progression for the last technique. So first you're going to be doing the 1 foot balance, and if you don't see any wobbling or any weakness, you can, like I said, do a Bosu ball or do the lateral bounding like we see here. But that is only if the patient feels comfortable and they pass the eye test with good balance and strength. So yeah, to wrap up, the corrective exercise plan uses a full progression of inhibiting, lengthening, strengthening, and integrating to address chronic ankle stability. And once you start working through that progression, like I said, you can start off with just normal balancing on a flat ground, and then also from there working up towards using a Bosu ball, doing the lateral bounding, using that as more of a progression for the patient. Thank you. This has been my video, and again, my name is CJ Shoemaker.